I'm Dr. Elena Rodriguez, and I had been a vascular surgeon at Meridian General Hospital in Phoenix, Arizona for 19 years, or at least I was until I submitted my resignation 6 weeks ago. During my career, I've performed over 3,800 vascular surgeries, restored circulation to limbs that were beyond salvage, and rebuilt arterial systems that seemed impossible to repair. But what I'm about to tell you about is the one patient that made me question everything I thought I knew about human blood flow, the limits of surgical reconstruction, and whether some medical miracles exist beyond the boundaries of science itself. Meridian General Hospital is a Level 1 trauma center serving the greater Phoenix metropolitan area, including parts of New Mexico and Southern California. As the chief of vascular surgery, I've encountered every type of circulatory emergency imaginable: massive aortic aneurysms that should have killed patients before they reached our doors, diabetic complications requiring intricate limb salvage procedures, traumatic arterial injuries from motorcycle accidents, industrial incidents, and cases where patients arrived with complete arterial occlusion but walked out weeks later with perfect circulation restored. My surgical training began at Johns Hopkins, where I completed my residency under Dr. Jonathan Hayes, one of the pioneers of modern vascular reconstruction techniques. I spent 3 years as a fellow at the Cleveland Clinic, learning advanced endovascular procedures and complex aortic repairs. By the time I arrived at Meridian General in 2005, I had already assisted in over 1,200 vascular procedures and published 17 papers in peer-reviewed journals. My team at Meridian consisted of some of the most skilled vascular specialists in the Southwest. Dr. Samuel Chen, my senior resident, had been working with me for 4 years and possessed an intuitive understanding of arterial anatomy that rivaled surgeons with decades more experience. My primary surgical technician, Maria Santos, had been in our department for 12 years and could anticipate my next move before I even announced it. She knew every instrument, every suture preference, and every step of my surgical protocols by heart. Our anesthesiologist, Dr. Patricia Williams, was renowned throughout Arizona for her expertise in managing high-risk vascular cases. She had successfully managed anesthesia for some of the most complex aortic reconstructions in the state's history, including a case where we replaced a patient's entire thoracoabdominal aorta in a single 18-hour procedure. Our perfusionist, David Kim, operated the heart-lung bypass machines that kept patients alive during the most complex repairs. His precision and quick thinking had saved dozens of lives over the years, maintaining perfect circulation even when we had to temporarily disconnect every major vessel in a patient's chest. If anyone could handle the medically impossible, it was this team. We had faced seemingly insurmountable challenges before and prevailed, but nothing in our collective experience prepared us for what we would encounter on that scorching August morning. The case that would ultimately destroy my confidence in everything I thought I understood about vascular medicine began on August 15, 2023. It was 5:47 a.m. when my pager buzzed with an emergency alert. I was already at the hospital, reviewing surgical cases for the day, when the message appeared: Level 1 trauma, multiple vascular injury, ETA 12 minutes, need you in OR4 immediately, critical arterial damage, minus Dr. Rachel Foster, emergency chief. I immediately headed to the surgical suite, where my team was already beginning their preparation. The emergency department had transmitted preliminary information that made my stomach drop. A 34-year-old construction supervisor named Isabella Martinez had been involved in a catastrophic industrial accident at a high-rise construction site in downtown Phoenix. A massive steel beam had fallen from the 20th floor, crushing her lower torso and completely severing multiple major blood vessels. "What's the damage assessment?" I asked Dr. Chen as we scrubbed in. "Complete transection of the abdominal aorta at the level of the renal arteries," he replied, his voice tense despite his usual calm demeanor. "Both common iliac arteries are severed. The inferior vena cava appears to be partially crushed. Paramedics couldn't establish a blood pressure reading at the scene. Blood loss estimates. Field medics estimate she's lost at least 60% of her blood volume. They've administered 12 units of blood products during transport, but she's been in profound shock for the entire 40-minute ambulance ride." When the paramedics burst through the doors of OR4, I knew immediately that we were facing an impossible case. Isabella Martinez lay unconscious on the gurney, her skin displaying the grayish pallor characteristic of someone who had lost massive amounts of blood. Her breathing was shallow and rapid, each breath a struggle as her body fought to maintain basic functions with critically reduced circulation. "Patient status." I called to the lead paramedic as we transferred Isabella to the operating table. 34-year-old female, crushed by approximately 2,000-pound steel beam, he reported while helping us move her. She was conscious when we first reached her, kept asking about her crew members, lost consciousness about 20 minutes into transport. We've been unable to detect blood pressure for the last 15 minutes. Downtime before you reached her. Construction workers estimate she was trapped for approximately 35 minutes before we could extract her from under the beam. It took 3 cranes working together to lift it off her. What I discovered when we opened Isabella's abdomen was the most devastating vascular injury I had ever encountered. The steel beam had not merely damaged her arteries, it had completely destroyed the central hub of her circulatory system. Her abdominal aorta, the body's main arterial highway, was severed cleanly in 2 places. The inferior vena cava, which returns blood from the lower body to the heart, was crushed beyond recognition. Both common iliac arteries, which supply blood to the legs, were completely transected. In medical school we learned that injuries of this magnitude are incompatible with life. The human body cannot survive for more than a few minutes without its central circulation intact. Yet Isabella had somehow endured over an hour with these catastrophic injuries, giving us an opportunity, however slim, to attempt a reconstruction that had never been successfully performed at our hospital. Starting proximal aortic control, I announced as we began what would become a 14-hour surgical marathon. The first challenge was stopping the massive internal bleeding. With her aorta completely severed, blood was pouring into her abdominal cavity faster than we could suction it out. Dr. Williams, monitoring Isabella's vital signs from the head of the table, provided regular updates. Blood pressure is barely detectable, 70/40, she called out. Heart rate 140, core temperature dropping to 94 degrees. She's in severe hemorrhagic shock. More blood products, I ordered, and start warming her aggressively. The complexity of the repair was unlike anything I had previously attempted. We needed to use synthetic grafts to completely rebuild Isabella's abdominal circulation, essentially creating new pathways for blood flow where her natural arteries had been destroyed. The procedure required connecting the graft to her aorta above the injury, then creating 2 separate branches to restore blood flow to both legs. Graft placement looks good, Dr. Chen observed as we positioned the synthetic blood vessel. Excellent flow through the main body, but 3 hours into the surgery, we encountered the first of several life-threatening complications. As I was creating the delicate connection between the graft and Isabella's right iliac artery, her blood pressure began dropping precipitously. "Elena, I'm losing her pressure," Dr. Williams announced, dropping from 85/50 to 60/35, now 45/20. I looked up from the microscopic sutures I was placing, checked for bleeding sources. "Maria, more suction here." But despite our efforts to identify and control bleeding, Isabella's blood pressure continued to plummet. Within 10 minutes it became undetectable. "I've got no pulse," Dr. Chen said, checking her femoral artery. Cardiac monitor shows extreme bradycardia. The heart rate monitor displayed a dangerously slow rhythm that was rapidly deteriorating. Isabella's heart, stressed beyond its limits by massive blood loss and the trauma of surgery, was beginning to fail. Starting internal cardiac massage, I directed. "David, prepare for emergency bypass if needed." Dr. Chen immediately began compressing Isabella's heart directly through the surgical incision, manually pumping blood through her circulation while I continued working to complete the vascular repairs. If we could restore her blood flow, we might still be able to save her. For the next 45 minutes, we fought desperately to bring Isabella back. Dr. Chen maintained cardiac compressions while I completed the arterial reconstructions. Dr. Williams administered every cardiac medication in our protocols. David Kim prepared the bypass machine in case we needed mechanical circulatory support. "How long has she been down?" I asked after what felt like an eternity. 38 minutes with no detectable pulse, Dr. Williams replied. "Core temperature has dropped to 89 degrees despite all our warming efforts. No corneal reflexes. Pupils are fixed and dilated." I checked Isabella's pulse myself, pressing my fingers against her carotid artery. Nothing. The cardiac monitor showed only occasional weak electrical activity that wasn't producing any meaningful circulation. Her skin had taken on the waxy grayish appearance that every surgeon recognizes as the look of death. After 42 minutes of aggressive resuscitation, I made the decision that haunts every surgeon. Time of death, 7:31 p.m. Isabella Martinez was gone. Despite 14 hours of surgery, despite completely rebuilding her abdominal circulation, despite every advanced technique in our arsenal, her body had finally succumbed to the catastrophic trauma she had endured. I stepped back from the operating table, exhausted both physically and emotionally. We had been so close to saving her. The vascular reconstructions were perfect. Blood would have flowed normally through the grafts we had placed. But sometimes, the human body simply cannot recover from injuries this severe. "I'll speak with the family," I told my team, removing my surgical gloves. "You all performed magnificently today. The reconstructions were flawless. Sometimes the trauma is just too extensive for anyone to survive. Isabella's family had been waiting in our surgical consultation room for over 14 hours. Her husband, Carlos, sat with their 2 young sons, ages 8 and 10. Her mother, Rosa, held Isabella's 3-year-old daughter, who had fallen asleep despite the chaos surrounding her family. Delivering news of a patient's death is the most difficult aspect of being a surgeon. No amount of training or experience makes it easier. I sat down across from Carlos and took a deep breath. "I'm very sorry," I said gently, meeting his eyes. Isabella's injuries were extremely severe. We worked for 14 hours to repair all the damaged blood vessels, but her body couldn't recover from the massive trauma she endured. She passed away at 7:31 this evening. Carlos's face crumpled, and he pulled his sons closer to him. Rosa began crying softly, still holding the sleeping little girl. The sound of their grief filled the small consultation room. After giving them time to process the news, I explained the extent of Isabella's injuries and the procedures we had performed. "I want you to know that she didn't suffer," I assured them. "She was unconscious throughout the surgery and felt no pain." "Can we see her?" Carlos asked through his tears. "Of course. Let me make sure everything is prepared, and then I'll take you to her." I returned to OR4 to ensure that Isabella's body was properly prepared for her family's final goodbye. The room was quiet now, a stark contrast to the intense activity of the previous 14 hours. The surgical instruments had been cleared away, and the monitors had been turned off. But as I approached the operating table, Dr. Chen, who had stayed behind to complete some documentation, looked up at me with an expression of complete bewilderment. "Elena," he said, his voice barely above a whisper, "something's wrong with the monitors." "What do you mean?" I asked. "We turned them off 45 minutes ago." "That's what I thought too," he replied. "But look." I followed his gaze to the cardiac monitor, which was displaying a steady, strong heartbeat. The blood pressure monitor showed readings of 110/70. The pulse oximeter indicated normal oxygen saturation. "That's impossible," I said. "The machines are malfunctioning." We disconnected her from everything. But as I approached the table to check the monitor connections, I noticed something that made my blood run cold. Isabella's skin, which had been gray and waxy when we pronounced her death, now had a healthy pink color. Her chest was rising and falling in regular, deep breaths. I placed my stethoscope on her chest, expecting to hear nothing. Instead, I heard a strong, regular heartbeat and clear breath sounds in both lungs. Isabella's eyes opened, and she looked directly at me with perfect clarity. "Doctor," she said, her voice surprisingly strong and clear, "is my surgery finished? How did everything go?" I stood frozen, staring at a woman who had been clinically dead for 47 minutes, now looking at me with bright, alert eyes and asking about her surgery, as if she had simply woken up from a peaceful nap. Every principle of medicine I had learned during my 24 years of training and practice told me that what I was witnessing was impossible. No human being survives 47 minutes without a heartbeat. No one recovers from complete circulatory collapse and regains consciousness asking coherent questions. The brain cannot function without oxygen for that duration without suffering irreversible damage. Yet Isabella Martinez was doing exactly that. "How are you feeling?" I asked, still unable to believe what I was seeing. I feel wonderful," she replied, sitting up on the operating table with surprising ease. "Better than I have in months." "What happened to me?" "I remember being at the construction site, and then nothing until just now." Dr. Chen was checking her vital signs with trembling hands. "Blood pressure 115/75, he reported in a shaky voice. "Heart rate 72, oxygen saturation 99%, temperature 98.4 degrees. All completely normal." I performed a rapid neurological assessment, expecting to find signs of the brain damage that should have resulted from 47 minutes without circulation. Instead, Isabella's reflexes were normal. Her memory of events leading up to the accident was intact. Her speech was clear and coherent. Her reasoning appeared completely unimpaired. "Isabella," I said carefully, "you were very seriously injured. You lost a massive amount of blood, and we had to completely rebuild several of your major arteries. At one point, your heart stopped beating for quite a while." She processed this information with remarkable calm. "How long was quite a while?" I hesitated, knowing how impossible this would sound. 47 minutes. You had no pulse, no blood pressure, no brain activity. By every medical standard I know, you are clinically dead." Isabella looked down at her hands, flexing her fingers experimentally. "But I'm here now," she said simply, "and I feel incredible. Actually, I feel better than I felt in years." As I would soon discover, Isabella Martinez's impossible recovery was not an isolated incident. It was the first in a series of cases that would challenge everything I thought I understood about vascular surgery, human circulation, and the very boundaries between life and death.
What happened in OR4 that August evening would set in motion a chain of events that would...
3 months after Isabella's case, in November 2023, I encountered Roberto Martinez, a 68-year-old retired mechanic who collapsed at his daughter's wedding reception from a ruptured abdominal aortic aneurysm. When I arrived in the emergency department, Roberto had been without a pulse for 23 minutes. His blood pressure was undetectable, pupils fixed and dilated, with no response to painful stimuli. The CT scan showed a massive rupture with extensive internal bleeding. How long has he been down? I asked Dr. Torres. 23 minutes without circulation. We've given him 12 units of blood, but we can't keep up with what he's losing. In normal circumstances, I would have declared Roberto dead, but after Isabella's case, something had changed in my approach. Let's get him to the OR, I said. If there's any chance, we have to try. Roberto's surgery was a 6-hour marathon that pushed every limit. His aneurysm had destroyed not just his aorta, but damaged surrounding vessels. We performed emergency aortic replacement, while his body temperature dropped to 87 degrees, and his pupils remained fixed and dilated. He's been down for over 4 hours, Dr. Walsh reported during the final phase of surgery. There's no brain activity, no reflexes. Despite completing a technically perfect vascular reconstruction, Roberto's heart finally stopped completely. We performed CPR for 31 minutes with no response. At 2:34 p.m., after Roberto had been without effective circulation for over 4 hours, I declared him dead. I delivered the devastating news to his daughter Maria, still in her wedding dress, that her father hadn't survived. 2 hours and 17 minutes after Roberto's death, Dr. Kim rushed into my office. Elena, you need to get to OR3. Roberto's monitors are showing a heartbeat. I found Roberto Martinez sitting up on the operating table, looking around with clear, alert eyes. Where am I? He asked coherently. What happened to Maria's wedding? His vital signs were completely normal. Blood pressure 125/82, heart rate 76, perfect oxygen saturation. After being dead for over 2 hours, Roberto was asking about his daughter's wedding with complete mental clarity. Roberto, you were declared dead at 2:34 this afternoon. That was 2 hours and 17 minutes ago. He smiled. Well, I guess I'm too stubborn to die. Maria always said so. Roberto's recovery was as complete as Isabella's. Within days he was home, reporting that he felt better than he had in years. His chronic arthritis was gone. His energy levels were higher than they'd been in decades. 2 patients, both declared clinically dead after massive vascular trauma, both returning after extended periods without circulation, both making impossible recoveries. I began researching Lazarus syndrome in medical literature, but found nothing comparable to the extended periods of death I had witnessed. Most documented cases involved minutes, not the hours I was seeing. 8 months later, in July 2024, 23-year-old Samantha Rodriguez arrived after a motorcycle accident. Her injuries were catastrophic: complete aortic transection, severed iliac arteries, crushed vena cava, plus massive internal bleeding. Despite being conscious and asking about her job interview, Samantha's blood pressure was barely measurable. Her 11-hour surgery was the most technically challenging of my career, requiring complete reconstruction of her abdominal circulation. In the final hour, Samantha crashed. Her heart stopped, and despite 46 minutes of aggressive resuscitation, I declared her dead at 10:47 a.m. This time, I decided to wait before informing the family. 53 minutes after declaring Samantha dead, her heart began beating again. She woke up asking about her Monday job interview. 3 patients, 3 impossible recoveries. The pattern was undeniable. Word of my unusual cases spread through the medical community. Some colleagues expressed curiosity, others questioned my diagnostic accuracy and medical judgment. Dr. Amanda Foster, our chief of staff, called me to her office in September 2024. Elena, I'm hearing concerning reports about your behavior in the OR. Colleagues say you're keeping patients on life support far longer than protocols recommend. What if they could recover? I asked. What if we're declaring patients dead too early? You can't base medical decisions on 3 unusual cases. These were anomalies, not evidence our protocols are wrong. But my confidence in those protocols had been shattered. I began extending resuscitation efforts far beyond normal limits, waiting longer before declaring death, second-guessing every decision. My surgical schedule ran hours behind. Colleagues complained about OR disruptions. Quality assurance reviews were initiated. In December 2024, Margaret Thompson, a 57-year-old teacher, arrived with a ruptured thoracic aortic aneurysm. Despite successful surgery, she died from massive blood loss and cardiac arrest. I waited 3 hours before declaring her dead. At 3 hours and 12 minutes, Margaret's heart began beating. She woke up asking about her students and Monday's lesson plans. This time, I had witnesses. Dr. Torres, Dr. Walsh, and 2 residents watched Margaret Thompson return from clinical death after over 3 hours. "This changes everything," Dr. Torres said quietly. "How many patients have we lost because we didn't wait?" Foster called an emergency meeting with hospital administration and department heads. "Dr. Rodriguez, we need to discuss yesterday's incident and your pattern of unusual cases. 4 patients have returned from clinical death," I said. 4 people declared dead, using proper protocols, came back hours later with perfect function. This challenges our fundamental understanding of death itself. "What you're suggesting is impossible," said Dr. Hayes from cardiology. "Dead patients don't come back to life. I have 4 documented cases that prove otherwise. Colleagues witnessed Margaret's resurrection. This is verifiable medical fact. What you have are medical anomalies that you're misinterpreting," Dr. Foster replied. "Over the following weeks I faced an impossible decision. I could continue practicing surgery, following protocols I now knew were inadequate, potentially declaring patients dead, who might recover, or I could leave medicine rather than participate in a system that couldn't acknowledge what I had witnessed. The choice became clear in January 2025, when I was assigned a patient with a ruptured aneurysm. Standing in the OR, looking at flatlined monitors, I realized I could no longer make life and death decisions based on protocols I no longer trusted. How could I declare this patient dead when I had seen 4 people return from clinical death? How could I tell families their loved one was gone when they might experience something beyond our current understanding? On February 14, 2025, I submitted my resignation. "Elena, you don't have to do this," Dr. Foster said. "Take time off. Maybe see a psychiatrist about these experiences." "Patricia, I've witnessed 4 people return from clinical death, not near death, actually dead by every standard we have. They all came back with perfect function. That's not supposed to be possible. Medical anomalies happen. You can't abandon your career over 4 unusual cases. These weren't anomalies. They were revelations. There's something we don't understand about consciousness, about life and death, about human existence itself. I can't keep practicing while ignoring that knowledge." I left Meridian General and moved to a small Arizona town where I now work as a family physician, treating minor ailments and avoiding life and death decisions. But those 4 cases haunt me. Isabella Chen, Roberto Martinez, Samantha Rodriguez, and Margaret Thompson were all declared dead using proper protocols. They all returned after significant periods of clinical death. They all made complete recoveries that defied explanation. Since leaving surgery, I've researched similar cases worldwide. They exist but are often dismissed or unreported. The medical establishment has no framework for patients who return from clinical death. All 4 patients continue living normal, healthy lives. Isabella returned to construction work with no medical issues. Roberto lived to see 3 more grandchildren before passing peacefully in his sleep. Samantha became a motivational speaker, sharing her resurrection story. Margaret continued teaching until retirement, and now volunteers at hospitals. They all ask the same question: why them? Why were they chosen to return? I don't have an answer. What disturbs me most are the implications for medical practice. How many patients have we declared dead who might have recovered if we waited longer? How many families have we told their loved one was gone when they might have been experiencing something beyond our understanding? The medical establishment prefers to classify these as anomalies rather than change established protocols, but I can't dismiss what I witnessed. I held Isabella's wrist and felt no pulse for 43 minutes. I watched monitors flatline for hours. I signed death certificates, then watched those same patients return to life. I found references to similar cases dating back decades, but they're scattered and dismissed. The phenomenon challenges our most basic assumptions about consciousness, death, and the nature of human existence. Some researchers theorize about pressure buildup during CPR, suddenly released when efforts stop, allowing circulation to resume, but this doesn't explain cases like Margaret's 3-hour death or Roberto's 2-hour absence. Others suggest our methods for determining death are inadequate, that we miss subtle signs of life, but I performed those examinations myself. These patients were dead by every measure I know. The most unsettling possibility is that consciousness and life exist in ways we don't understand. If Isabella could observe the operating room while clinically dead, if Roberto could somehow choose to return, if Margaret could experience awareness during 3 hours without circulation, what does that say about human consciousness?
Isabella, Roberto, Samantha, and Margaret have all described similar near-death experiences. They floated above their bodies, observed the medical teams, encountered deceased relatives, and faced a choice between moving toward light or returning to life. They all chose to return because of unfinished business. Isabella for her family, Roberto for his daughter's wedding, Samantha for her future, Margaret for her students. Each described feeling better after their resurrection than before their injury. Complete healing, not just of their trauma, but of chronic conditions they'd had for years. Witnessing these resurrections changed my understanding of medicine and human existence. The heart that beats after death, the consciousness that persists without circulation, the perfect recoveries that defy explanation. They revealed how little we understand of
family medicine. The red rocks outside my window provide a stark contrast to the sterile hospital environments where I spent nearly 2 decades of my life. But even in this peaceful setting, the 4 impossible cases that ended my surgical career continue to haunt my thoughts daily. Isabella Chen, Roberto Martinez, Samantha Rodriguez, and Margaret Thompson. 4 patients who returned from clinical death. 4 people who challenged everything I thought I knew about the boundaries between life and death. 4 cases that the medical establishment refuses to acknowledge as anything more than anomalies. But what I've discovered in these past 6 months of research has convinced me that what I witnessed was far from anomalous. It was a glimpse into a phenomenon that's been occurring for decades, systematically ignored and dismissed by a medical system that isn't ready for its implications. After leaving surgery, I dedicated myself to researching similar cases worldwide. What I found was both fascinating and deeply disturbing. Using medical databases, journal archives, and direct correspondence with physicians around the globe, I've documented over 200 cases of extended clinical death followed by complete recovery since 1980. Dr. Hiroshi Tanaka from Tokyo General Hospital contacted me after reading about my cases in an online medical forum. He described 3 patients who had returned from clinical death, including a 45-year-old businessman who was dead for over 4 hours after a massive heart attack, then woke up asking about a business meeting scheduled for the next day. The medical community here dismissed it as measurement error. Dr. Tanaka told me during our video call, but I know what I witnessed. The man had no pulse, no brain activity, body temperature of 85 degrees. He was dead, and then he wasn't. Dr. Da Mitchell from Edinburgh Royal Infirmary shared similar cases from Scotland. Dr. Carlos Mendoza from Mexico City described a pattern identical to mine. Dr. Priya Sharma from Mumbai had documented cases dating back 15 years. The pattern was global, consistent, and completely ignored by mainstream medicine. What shocked me most wasn't the existence of these cases, but the systematic way they were being suppressed. Hospital administrators discouraged physicians from reporting them. Medical journals rejected papers describing the phenomenon. Conference organizers withdrew speaking invitations from doctors who discussed extended clinical death recoveries. Dr. Robert Chen, no relation to Isabella from Johns Hopkins, told me he had witnessed 12 cases over his 30-year career, but had never published about them. The medical establishment doesn't want to hear about patients returning from clinical death, he said. It challenges too many fundamental assumptions about consciousness, brain function, and the nature of death itself. I discovered that several physicians had lost their positions or been quietly forced into early retirement after reporting multiple resurrection cases. The medical community had developed an informal but effective system for silencing doctors who witnessed what I had seen. Despite the official silence, an underground network of physicians, researchers, and scientists has been quietly studying this phenomenon for years. Through encrypted communications and private meetings, we've been sharing data, comparing cases, and developing theories about what we're witnessing. Dr. Elizabeth Warren, not the politician, a neurologist from Harvard, has been conducting secret brain imaging studies on resurrection survivors. Her preliminary findings are extraordinary. The patients who return from extended clinical death show brain activity patterns I've never seen before, she told me during a clandestine meeting in Boston. Not just normal activity, enhanced activity. Areas of the brain that are typically dormant show significant activation. It's as if the experience of clinical death somehow upgrades their neural functioning. This would explain why Isabella, Roberto, Samantha, and Margaret all reported feeling better than they had in years after their resurrections. Their brains weren't just recovering, they were improving. Dr. Patricia Williams, a consciousness researcher from the University of Virginia, has been studying the near-death experiences reported by resurrection survivors. The consistency of their accounts is remarkable and troubling. Nearly all patients describe similar experiences: floating above their bodies, observing medical teams, encountering deceased relatives, and facing a choice between moving toward a bright light or returning to life. But resurrection cases involve much longer periods of observation than typical near-death experiences. These patients are describing detailed conversations with medical staff that occurred hours after they were declared dead, Dr. Williams explained. They're reporting events from other parts of the hospital, conversations between family members in waiting rooms, even phone calls made by relatives from their homes. This suggests consciousness persisting and even expanding during clinical death. Isabella had described seeing her husband David crying in the parking lot and calling her sister from his car, events that occurred 2 hours after her death declaration. When I verified this with David, he confirmed every detail she had described. From a purely medical standpoint, what I witnessed should be impossible. The human brain begins suffering irreversible damage after approximately 4 to 6 minutes without oxygen. After 20 minutes, severe neurological deficits are inevitable. After an hour, brain death should be absolute and irreversible. Yet Isabella was clinically dead for 43 minutes, Roberto for over 2 hours, Margaret for more than 3 hours, all returning with perfect neurological function and enhanced well-being. Dr. Kumar Patel, a biomedical engineer from MIT, has developed a theory about what he calls cellular hibernation. His research suggests that under extreme stress, human cells might enter a dormant state that dramatically reduces their oxygen requirements, allowing survival during extended periods without circulation. We've seen similar phenomena in certain animals that can survive freezing or drowning for extended periods, Dr. Patel explained. Perhaps humans have a latent ability to enter this state during life-threatening trauma, but we don't recognize it because we declare death too early in the process. The most disturbing aspect of these cases isn't the physical recovery, it's the implications for consciousness. If patients can observe events while clinically dead, if they can make decisions about returning to life, if they can interact with deceased individuals, what does this say about the nature of human consciousness? Dr. Michael Harrison, a quantum physicist turned consciousness researcher, believes we're witnessing evidence that consciousness exists independently of brain function. These cases suggest that what we call mind or soul persists during clinical death and can return to reanimate the body under certain circumstances. This theory challenges fundamental assumptions of materialist neuroscience, which holds that consciousness is purely a product of brain activity. If consciousness can exist without brain function, then death as we understand it might be a transition rather than an ending. My investigation into these cases has come at considerable personal cost. Former colleagues avoid me at medical conferences. Research institutions have withdrawn funding opportunities. Medical journals refuse to consider my submissions. Dr. Amanda Foster, my former chief of staff, called me last month. Elena, people are saying you've lost perspective, that you're promoting unscientific theories about consciousness and death. You're damaging your reputation and credibility. Amanda, I witnessed 4 people return from clinical death. I have documentation, witnesses, test results. How is reporting medical facts damaging to credibility? Because you're drawing conclusions that challenge established medical science. You're suggesting patients can survive hours of clinical death, that consciousness exists independently of brain function. These aren't medical facts, they're metaphysical speculations. But I've seen too much evidence to remain silent. Isabella Chen continues to work in construction with no medical issues. Her annual checkups show optimal health, and she's become an advocate for extended resuscitation protocols. Roberto Martinez lived 2 more healthy years after his resurrection before passing peacefully in his sleep, a natural death at age 70. Samantha Rodriguez completed her college degree and now works as a biomedical researcher, partly inspired by her own impossible recovery. Margaret Thompson volunteers at hospice centers, comforting families facing death by sharing her unique perspective on what lies beyond. All 4 maintain that their resurrection experiences were the most profound events of their lives. They describe feeling chosen, blessed, or selected for reasons they don't fully understand. They report ongoing enhanced intuition, improved health, and a profound lack of fear regarding death. After 6 months of research, I've reached conclusions that I know will seem impossible to many in the medical community. But the evidence is overwhelming. Human consciousness appears to persist during clinical death. Patients can observe events and make decisions while brain activity is undetectable. Under certain circumstances, consciousness can return to reanimate the body after extended periods of clinical death. This suggests that death, as we currently understand it, may not be the absolute boundary we believe it to be. It may be a transition state from which return is possible, though rare and not well understood. If even a small percentage of patients declared clinically dead might recover with extended waiting periods, we need to fundamentally reconsider our death declaration protocols.
How many lives might be saved if we extended resuscitation efforts beyond current guidelines? How many organ donations might we be preventing by harvesting organs from patients who could potentially recover? The ethical implications are staggering. Are we ending treatment too early? Are we missing opportunities to save lives because we don't understand the true nature of clinical death? I know this account will be dismissed by many as the delusions of a surgeon who couldn't accept losing patients. Medical colleagues will suggest I've lost objectivity, that grief over patient deaths has clouded my judgment. But I've documented every case, verified every detail, and connected with researchers worldwide who are witnessing the same phenomena. The evidence for consciousness persisting during clinical death is overwhelming, once you look beyond the institutional bias that refuses to acknowledge it. The 4 patients who returned from death changed more than my understanding of medicine. They revealed the extraordinary nature of human existence. We are not simply biological machines that cease functioning at death. We are conscious beings whose essence may transcend the physical limitations of our bodies. This truth cost me my surgical career, my professional reputation, and my standing in the medical community. But it gave me something far more valuable, knowledge that death is not the end we believe it to be, and that consciousness may be the greatest mystery of human existence. Some will call this fantasy. Others will recognize it as the beginning of a new understanding of life, death, and what it means to be human. The dead don't always stay dead, and that changes everything.